Good morning, everyone. Today we are hosting a podcast about calcium modification in 2026 from GIS Conference 2026. I'm Wael Abashoka, Consultant Intervention Cardiology from Qasimi Hospital, UAE. We have Dr. Faisal Al-Koufi from Saudi Arabia and Dr. Shaza Al-Alawi from Saudi Arabia. And we will be discussing today with them. First, Dr. Faisal, would you give us your insight about the burden and the risk of severe and moderate calcification in the current era?
Great question. To start with, initially we had the difficulty identifying calcification both an angiogram. Almost 30% of the coronary angiography that we perform in a contemporary cath lab will have calcification. The issue with the angiographic identification has the lack of specificity and the sensitivity for identifying calcification. A wealth of data has been accumulated over years to indicate that the procedure that involve various degree of moderate to severe calcification carries with it risk of peri-procedural complications and also suboptimal outcome related to the target vessel revascularization in the future. So in summary, a calcified lesion has to be taken seriously in terms of moderate and severe calcification, and the planning of such process is very important to achieve great outcome.
That's very good. And although, as Dr. Faisal have mentioned, around 30% of the cases has some degree and maybe 6% have severe calcification, the usage of calcium modification is not more than 2% in the meantime. So, Dr. Shaza, what are the tools available? Why is underutilized these tools, and what are the available tools for calcium modification?
Well, we have plenty of tools that we are using during plaque modification, starting from the balloon modification using cutting balloon and angiosculpit to more invasive rotablation and rotational atherectomy. It depends usually on the intravascular imaging criteria, whether you have a high calcium deposition within the vessel wall. So you should choose between each tool. It depends on your intracoronary imaging. So usually when you have a superficial more than 27 arc calcium or calcified nodule, you go more aggressive with the rotablation. And if it's just scattered calcium, you can use the cutting balloon angiosculpit and it can work. The most important thing is the more superficial is the calcium, the more you gain from the plaque modification tool. The deepest the calcium is, we use more of the IVL, the shockwave with the deep. The superficial, I think the rotablation and rotational atherectomy, I use it more frequently in our cath lab. So Dr. Faisal, do you have any preference in using the shockwave rather than rotablation? Yani you consider rotablation when you have calcified nodule and more superficial, and you have deep calcium, you take more of IVL?
I think it's an excellent question, and how this will drag us into how we treat in a day-to-day basis, how we are treating calcified lesions. I think the most important thing for any cath lab who is dealing with calcified stenosis is to gather what is the area of expertise. Most operators currently are equipped with lots of data to indicate that most of the currently available debulking and modification device are reasonably safe. And compared to a couple of years ago, now we have algorithm in our cath lab that start, for example, with are you able to cross or not cross? And once you cross, once you image, are you able to quantify the degree of calcification? And depending whether the calcium is deep versus superficial, I will choose between the debulking device. My routine in the cath lab currently is if I'm able to cross with an imaging device, then I definitely have to quantify the calcification and the arc of calcification. And if I am not dealing with a calcified nodules, then definitely based on the recent data from the TCT, certain operator might start with a cutting balloon or a non-compliant balloon. But the most important thing is to keep in the algorithm, when do I have to start with a rotational atherectomy or with orbital atherectomy? Specifically, if you have difficulty to cross or if you have a calcified nodules. We have to remember that our aim at the end of the day, irrespective of the tool, is to reach to one thing: safe procedure and a well-expanded stent. Because if you achieve a well-expanded stent, then you know your outcome is good.
So I have also an input here. Although we have all this kind of equipment, and the more your armamentary you have, and the more tools you have, you need to have this kind of algorithm. And as we were talking about superficial and deep calcium, I think for, as you said, deep calcium, you need IVL, superficial calcium, you need rota or atherectomy, rotational atherectomy. But the new kid in the block now, it's not so new, the orbital atherectomy, which can work on both deep and superficial calcium. And if you utilize it in the proper case, you get a really better luminal gain. And I think this takes us to where in each cath lab, in my cath lab in United Arab Emirates, in your cath lab in Saudi Arabia, how do you approach your case? As Dr. Faisal have said, this is the algorithm they use. Do you have a different algorithm?
For me, once I see a calcium, if I just want to cross with IVUS and it did not cross, I don't do anything. It's a rota case for me. I don't do any ballooning, I don't try. Because really, if you did not do a good black modification, you will regret doing any ballooning and you waste the chance to do rotational atherectomy. So my routine approach is to cross with IVUS. No cross, it's a rota case.
It's the same for me. We prefer in our cath lab for calcific lesions, really OCT, if the renal functions are okay, because OCT gives you better idea about the thickness of the calcium, and this can modify your strategy. And if the OCT or any imaging IVUS will not cross, we'll go directly for atherectomy, either by rota or by orbital atherectomy. And adjunctively, we can use a cutting balloon after a rota cut, or an IV orbital cut, or a shock wave. And I think it's the same. We are all in the same wavelengths, and so I think that by this we can conclude our broadcast. And here in Dubai, we are very happy to have you today.
Thank you, Dr.
Our friends, our colleagues from Saudi Arabia, and hope next year we'll see you and we have another broadcast.
Thank you.
Thank you, everyone, and I hope that it was a beneficial and fruitful discussion.
Thanks.